Hey folks, welcome to the Changed Physician Podcast. This is your host, Dr. Kevin Cuccaro, and I'm here today with my co-host, Dr. Melissa Cady. And our guest is Dr. Peter Lehmann. Dr. Lehmann is in the Seattle area who had a very long-standing practice with a large medical group up there, then made the transition into direct primary care, has been thriving ever since, so we want to get into that. But we are going to hear about his physician journey and really why he went in medicine, the struggles that he had, and why ultimately he made the decision to go into direct primary care and his experiences since then. So, Peter, great to have you on the show. Thank you for coming in.
Thank you so much.
Awesome. Well, I guess we should start from the beginning. Kevin has a little of a head start in knowing more about you, but I'd love to hear a little bit of why you went into medicine in the first place.
Sure. So my dad was a physician, and so I had a very romantic notion of what a physician was because he became a physician in the mid-50s. And I don't know, growing up, I still thought of docs as kind of like the small town doc that everybody knew and you could count on them to take care of whatever came your way. And it was a very nostalgic view. And I was smart. I was, one of the A students. And so I knew I wanted to do something with my life that was going to allow me to use my smarts. And so for me, I never really thought about doing anything else. I can remember really vividly, I was about 10 and my dad and I were fishing. And I don't know, the conversation came up. He said, well, what do you want to do? And I said, well, I'm going to be a doctor. And literally there was never any other consideration that I would be anything else other than a doctor. It was just like, oh, I am a doctor. I just need to figure out how to be one. I just need the knowledge. It was destined.
Yeah, you just had to go on that path and do what you're told and you'll get there.
Pretty much, it isn't like other fields of business or whatnot where you have to kind of figure out how you're going to do it. It's just once you decide to do it, it's all laid out for you. You just have to, take the path and, cross through everything.
Yeah. So you knew from the age of 10 you wanted to be a doctor, and you enter medical school. Right. And then so medical school and residency, did that sort of confirm your ideas of what being a doctor was, or was there something else that happened during that time?
Yeah. Well, first off, I'm one of the weird people who loved medical school. I mean, I loved it.
Yeah.
Every day, I mean, maybe I've blotted out some of the memories, but literally the memories I have of medical school was fantastic. I loved learning a lot. It didn't bother me to be overloaded. Once I stepped on campus, I went to GW in Washington, D.C. Once I stepped on the campus there, it was this immense feeling of awe that I was actually beginning to realize my dream. And I hit medical school just at the right time intellectually. I slacked off a little bit in college and didn't get the best grades I could have possibly. But when I hit med school, things were just right. I was super psyched. I was probably at the top of my game intellectually. And so I loved medical school. I loved every rotation I did. There wasn't one that I didn't really enjoy. So Kevin said I'm an internist. I'm actually a step higher. I'm a family physician.
Oh, I would say that too. Yeah, no. I can't believe I got that wrong. I'm so embarrassed because I hang out with mostly family physicians. So
yeah.
But I was wondering that when you were saying, because you're like, I loved every rotation. I was like, did I get it wrong? Because that's the family physicians generally say.
I mean, when I was getting towards the end of medical school, I was like, okay, I got to figure out what I'm going to do. And I literally said, I loved everything, whether it was inpatient or outpatient. And I had this romantic notion of what a doctor was. And so I'm just going to be a family doctor because that's the thing. Plus, I really did I liked everything, but I really liked my family medicine rotations because from the beginning, I really thought it was all about connecting with people, especially listening to people and letting them involve me in their lives. And so I was very big on that. No matter what the rotation was, I really liked listening to people and hearing their stories. And family practice was the widest possible variety of stories like that. And I would be able to kind of have a relationship, potentially it could be very long term. Like, depending on where I went, maybe I would take care of people my whole practice. So once I sort of said, oh yeah, I think I'll be a family doctor, there was no looking back. It's like, that was the way to go. And it was great in the early years.
Until when?
I honestly think, well, let me back up. So I am like Kevin. I did military service to pay for medical school. Only I picked the branch, you know, where people are like seriously gung ho. I was Army. Kevin was Navy. So, you know, give him a little slack there. But so I did my residency in the military, and then I did 3 years active duty in a military hospital, community hospital that had a clinic attached to it. So I got to kind of see what, oh, I guess you'd sort of say like Medicare for all kind of thing. I got to see what, whatever you want to call it, socialized or big organization. I kind of got to see how a doctor fit in that. And I enjoyed it because I was taking care of retirees and pregnant wives and active duty soldiers. I liked the variety, but I didn't really like the system so much. It was kind of a restriction. And when I closed the door, I felt like, okay, I'm being the doc when I'm in the exam room. When I finished my military time, I really wanted to go into private practice because I felt like that was going to be, you know, fulfilling the romantic idea of being a doc. And I came out and joined a really large practice in the Seattle area. I was a shareholder owner, and we started out with about 30 docs, ended up about 60, multi-specialty. And at the beginning, things were not too bad. I lay the downfall when the push came for electronic medical records, which was 2008, I think. I love technology. I mean, I used electronic medical records from before they were even reasonably easy to use. So I was really into the idea, love it. But we got electronic medical records, and the government said, hey, here's some money that we'll give to you so you'll adopt it. I was like, that's cool. Then they said, yeah, but it's only going to be ones that we approve. And then they said, you've got to show us that you're using it in a way we think is meaningful. And, you know, that just sort of steamrolled into everything that is today. And I found, like most other docs, I was spending huge amounts of time on the computer trying to chart and trying to make sure that the charting met the billing standards, which is kind of where things have gone. And what I found in my practice was the EMR became just a huge albatross of debt that we all had, because we always had to be upgrading. We had to hire people to run the services for us. And once insurance companies started paying really close attention to electronic medical records was when they really got into details and what most docs know certainly about, you know, checking boxes and the like. And so in my private practice, it became very tedious. It took away from time I could spend with patients. And we started to have to pay more and more staff just to administer everything. So you put that along with reimbursement rates being pretty flat overall, especially in primary care. So unless you want to lose a lot of money, you have to start seeing more people because your reimbursement rate's pretty flat, but your cost of seeing each patient goes up. So I found in the last 2 to 3 years before I left that practice, it was just a grind, just all day long. And I would stay till 9 or 10 o'clock at night. And I was either running really, really late or shortchanging patients. And I started to just get this really sick feeling that I wasn't doing what I loved. And I was kind of having to shoot from the hip, taking care of patients way more often than I liked. And so to me, unfortunately, the thing that could have been great, you know, computerization of electronic records, to me ended up being the downfall. And I talked to most other docs, and that's the thing they probably hate the most.
Yeah. And that's a whole nother topic, because there's so much to go in there that something that had so much promise was just bastardized and destroyed. And the only people that I know that benefited from electronic medical records were the vendors who made electronic medical records.
Right.
But I want to, because it's kind of interesting, is you stayed pretty focused through that time up until, because that's not that long ago, if you consider.
Seems like ages ago to me.
Well, maybe time does seem to go a lot faster now, but you seem pretty optimistic. And what I mean by that is when we start hitting the grindstone even more and we're in these practices and we have all these onerous sort of requirements and these external factors that are coming in, people start feeling like they're burned out on medicine. But
Right.
It sounds like you still enjoyed medicine. You were burned out on the system that was trying, that medicine was being delivered in. And it's a little bit different level of awareness. Am I correct in that? Or
Yeah, so I was never tired of what people needed from me, patient-wise. It was just the grind of doing things that had nothing to do with taking care of patients. And so I never would have burned out if I could have taken care of patients in that nostalgic way that I had time for when I was in training, because they give you extra time in training. If you're in med school or even if you're a resident, they allow for extra time for appointments and whatnot. Well, when that's taken away and you're trying to see a lot of people and you care, like I do, about the whole person, like you have to have time. Like you just plain and simple have to have time. And time was the one thing that was just getting smaller and smaller and smaller, and still is for people who are practicing third-party reimbursement. So, yeah, I mean, I realized the way the system worked that was causing trouble. And I'm almost 57 now, so this was about 7 years ago that I really started asking questions of what was I going to do. I was 50 years old and I could not imagine how I was going to remain a doctor any longer. I just, kind of dreaded Mondays. And I just said, I can't keep doing this. Like I literally can't do it. But I love being a doctor. What am I going to do? Mm-hmm. And I lucked out. I found out there was something else to do, which was direct primary care.
So being at that point of transition, who or what was the thing that gave you a little glimmer of hope?
Yeah, this is kind of a funny story. My oldest daughter was a high-level soccer player in high school. And so I was the one who took her to all of her games. And so we'd have to get to the games really early. And so I would usually just sit in my pickup truck and drink coffee while she was there 2 hours ahead of time. And I was listening to just like little short CMEs for docs. And one of them was like 5 minutes long. And I think I got like 1 credit. And I think it was called something like, either it was direct primary care or was like, make $200,000 a year seeing 500 patients, something along those lines. I was like, oh, that sounds kind of interesting. So I listened to this little 5-minute talk that basically said, you know what? You can have the life you want as a doctor. Stop taking payments from any third parties, work directly for your patients, have them pay you an affordable monthly fee, and do whatever they want. And you'll be able to cut down the number of patients you have in your practice, and you'll be able to have whatever the practice means to you. That's the way you'll be able to set it up. And it was just 5 minutes. It was literally, it's this straightforward. And I said, that's my salvation. That's what I'm going to do. That's what's going to let me do what I want to do forever. Like I won't have to think about retiring unless I just want to. And after I heard that, the doc who put out the CME, his name is Josh Umber, and he's one of the earliest docs who got into direct primary care. And I actually called him from my truck while I was waiting for the game, and I spent like an hour on the phone with him, just peppering him with questions. And I knew from that moment, this is what I'm doing. I just have to figure out what do I have to put into place to make it happen. There was no question. There was no question that it was going to work.
Yeah. Well, that's amazing. From 5 minutes that it just planted the seed, and you went ahead and watered it right then, and made yourself, feel like it's a possibility. So how long what's that?
Well, it was one of these things where when I started thinking about it, I thought, okay, this is going to be good for me
Uh-huh.
because I'll have a decent living. I don't make any promises about 200,000 or whatever it happens to be, but
Sure.
I knew I'd make an okay living. That would be good for me. I would have fewer patients, so that's going to be really good for me because I can really use all my skills. It's going to be really good for the patient because they're going to pay once a month and I can be available to them whenever they need me, whether it's at night or on the weekend. And I can do long appointments because time was this thing that was so missing. So I said, this is good for the patient. It's good for me. In a weird way, it's good for the insurers because they don't have to deal with these nickel and dime claims. And then one of the things I learned from Dr. Umber was, look, why don't you give a whole bunch of value to your patients? Why don't you dispense medications like a pharmacy in your office? Order generic medications wholesale and dispense them. It's like, wow, that's going to be good for patients. And he said, you know, you can contract with big labs and they'll give you cash prices for labs and bill you once a month, and you can just bill your patients the same amount. It's like, wow, this is good. A lab likes it. Generic medication manufacturers like it. I like it. Patients like it. And we've branched out since. We've talked to radiologists who say, oh, we'll do a CAT scan for $200 for cash. So after this 1 hour talk, I said, oh, this is like good for everybody. And so I said, it can't fail. And literally it was like, oh, it can't fail. And it hasn't. It's been very successful.
I think patients, once they experience, I mean, the crazy thing is that the way you described how not take insurers and like directly charge your patient and give value to them, you know, like full transparency, like
Right.
it sounds, it's just funny that we even have to say that. Like that's the way it should have been from the beginning and never changed in my personal opinion.
Right.
Because there was such a downstream insidious effect over society that now it's been constructed so in a complicated way, it's hard to extricate it from itself. I think too many third parties that are benefiting from the whole pie that they're trying to take. Anyway, I just think yeah, go ahead.
You're right. I think docs have kind of been doing this long enough. They're kind of brainwashed.
Mm-hmm.
Kind of like this whole Stockholm syndrome or whatever, where you begin to identify with your captor. I think most docs who are, well, probably younger too, because they never knew any of the good old days, but you sort of get stuck in this system and you just sort of think, well, it is what it is. It's the way it is. There is no other alternative unless you want to be like a Beverly Hills, you know, have 100 patients and they pay you, you know, whatever, $10,000 a month. Nobody thinks that there's any other way. And once this sort of starts ringing bells, you say, oh, that sounds like a really great idea. And once you've done it for a while, like I'm in my 5th year, I'm so used to it. I have to realize that when I talk about this, like doctors' heads kind of explode, like they literally can't comprehend it. Or a patient, once I explain it to them, they get it. But when they first hear it, it is so like bizarre. But doctor, I already have insurance. Why would I do that? And you have to sit down with people and say, okay, what's your deductible? Like, how often do you go in? What does it cost when you go for a visit? How easy is it to see your doctor? I'm so used to it that it just seems like, well, of course you would do it this way. Yeah. But I have to remember that it is sort of shocking for people to hear this. But I tell patients, you know, 50 years ago, your parents just called the doctor up, came to his office, he did what they needed, and they paid him. And the only thing wrong with that was the same thing that was wrong with the system we've created, is it was dependent upon volume. How many people could you see? So if somebody's paying you, you know, per procedure or per visit, whether it's the patient or the third party, you're dependent upon a large number of patients. And the only difference is in the old days, you could keep your notes on a simple little pad of paper or a note card, but it was still volume driven. The worst is the current system, which is it's volume driven. You just have to see a lot of people and you have to write a ton of information down for the visits. So this is like the optimal. People pay you a set amount. So, you know, as a doc, I know how much money's coming in, and I know how much it costs to run the practice. I know what I'm going to make each month. And then it doesn't matter how many times people call me. I'm perfectly happy. So I wish more docs and more patients could see the simplicity of it, but it seems so like out of, I don't know, out of the mainstream and normal. It's really hard for people to grasp until they get it. And once they get it, it's like, oh, this is fantastic.
And I think that's important because you say if you even say I'm a cash-based practice or whatever with a membership model, I'm curious, do you ever have people say, well, I can't afford you then, before they even hear what your rates are?
Oh yeah,
so
for sure.
Because it's always astounding to me. Like as soon as you say that in anything, people are like, I can't afford you. And like, well, you haven't actually asked. And like you said, have you ever looked at your bill? And what really hit home to me was when my mother-in-law got from her visit, it was, 15 minutes or less kind of thing. And someone checked all the boxes and upcoded to whatever, 4 or 5 visits.
99214 at least.
Yeah. And I'm like, this is being billed for like $400 and something, and her copay was like $120. And I'm like, this is freaking nuts. And even more nuts to me, because I'm like, and I'll let you go into it. Like, could you just tell what your rating structure, like what's your pricing structure for people who may be thinking, oh, I can't do this, or these are just for rich people and blah, blah, blah.
So 0 to 20 years old is $15 a month. 21 to 40 is $45 a month. 40 to 65 is $65 a month. Anybody over 65 is $85 a month. If you make it to 100, it's $1 a month.
I love that.
So the crazy thing to me is initially I was like, oh my gosh, how much am I going to charge? And what are people going to think? And for the value I give to patients, quite honestly, it's a steal, really. And I'm fine with it. I mean, I make a perfectly okay living. I'm not making a lot. I'm not making a little. But I do have some patients that'll say, wow, $65 a month. And they still are thinking, well, it seems like a lot of money. But if people will just slow down and think about, their Starbucks or how many times they go to a restaurant, it's really not that much. And once people get into my practice, like, people don't leave. They certainly don't leave for money. I mean, maybe they move, but yeah, this is very much for the average person. We have about a third of my patients are Medicare. Like, so for them, it's not like they're saving any money. It's not they're saving their copays, but they love the relationship. And then about maybe 40 to 45% are commercially insured patients, usually with a high deductible or lots of copays. And then the rest are uninsured patients. They love it. I mean, who wouldn't? Like, I make hour-long visits. Like, we'll shorten it down if the patient doesn't have time, or we'll shorten it down if it's literally like one small little thing. But every patient gets lots of time. And we do technology. I don't need to see the patient in the office to bill. And now with COVID, there's a lot of stuff going on where people are now able to do Zoom meetings. But from the very beginning, I said, well, if you don't need to come into the office, why come? If you have a rash, just send me a picture. Or let's just do a quick video visit. You could do it from work on your lunch hour. So once people sort of see the entirety of it, they realize, wow, this is actually a pretty good deal. And I think most docs are kind of surprised that that's as little as I charge people. I think most docs would think, oh, wow, I thought you'd charge a lot more. Yeah. And there are some who do charge more. Either they want to, higher income, or they want to see less people. And so you have to just kind of look and say, if you're going to see less people, you probably need to charge more. But the great thing is you can make the practice whatever you want. Yeah. You can decide whatever you're going to set the price as. You can create your practice to be like day to day of seeing patients, whatever you idealize as your practice. And who knows, it might be having a practice that's heavily geriatric. It might be, I don't know, You want to do your visits outdoors. You want to take your patients on a walk for your visit. I don't know, whatever it happens to be.
Yeah. I love the convenience of what you, or value, I should say, that the convenience is part of that value of just how you bring everything either within your own practice, whether it's the medications or whatnot. And obviously there's no real big surprise bills when it comes to some of these, sometimes the labs or the imaging and whatnot. That I mean, I think it's sometimes for those that are on the fence, once you experience it, you know that you love it better than the traditional
Right.
system.
It is freedom. True. It is literally like physically liberating
Yes.
to do this. And the great thing is my patients know exactly to the penny what anything costs. So anything I can do in the office, a joint injection, sutures, regular office visits, if I can do it, it's included. The only thing that's extra is if they need a lab or want a medication or like an x-ray. Well, those are all negotiated prices.
Mhm.
So they know exactly what it is. So, and it's ridiculous how low these vendors will drop their prices. You know, we do an A1C for like $3.20.
That's so crazy.
You know, a comprehensive metabolic panel I think is $3. So if I say to the patient, I want you to get this test done, and they know it's a pass-through, I take no cut of it. They know exactly what it costs, and they know I have no vested interest in having them get the test, other than I think they need the test.
Mm-hmm.
So there's literally no surprises ever. The patients know exactly, so they love it.
Yeah, I'm curious, what is your take on why they go so low? Is it just because you do the phlebotomy draw in-house and it takes away from all the extra work they have to do over there? Why is it you think they drop so low?
It takes away from all the billing, I think. So what happens is throughout the whole month, my patients are getting labs either here or they'll get them drawn at the lab station. We use either LabCorp or Quest. I get a bill itemized at the end of each month because I'm the client to the lab, itemized with all the tests they did. I write them one check, they're done. So the amount of overhead they get rid of is huge because they just automate one bill to me and I write the check. So they don't have to deal with a claim for every single one of these. They don't have to deal with claims coming back because there wasn't a code that justified the lab. I mean, there's just all sorts of reasons.
Gotcha.
Cash is amazing. Go to a car dealership with, $50, $100 bills and say, here it is. This is what I'll pay for that. They'll take it. They won't haggle.
But I got two things I really want to kind of hone in on for a second here.
Sure.
The first one though is because you're like, oh, this is freedom, but I can just hear a listener, kind of stuck in a practice with call and all that stuff, and it's like, but I'm sure those, he just said they can get him whenever, so they're calling him on the weekends and at midnight with their hangnails. What has your experience as being as basically the old time country doc who is on call all the time?
24/7, 365. I would say, let's say in an average week, I better even say longer than that. In the average 2 to 3 weeks, I get maybe one call at night. Patients will text me or send me an email in the evening, and they know that if I feel like it, I'll reply back. If I don't, I'll reply back in the morning. It is fantastic because people know it's always me, always. And because we know each other so well, because we do lots of long visits, there's very little that comes up at night that's truly urgent.
Yeah.
So I wondered how it would go, but I've been doing this 4.5 years. I am ready at the drop of a hat to see a patient on Saturday or Sunday here in the office. Like if I can keep them out of urgent care, saves them a ton of money. I'll bet in 4.5 years, I've come down to the office like less than 10 times. It's a totally different experience when people have a relationship and they know they can see you easily. And I talk to DPC doctors around the country. Nobody gets burned out about after hours care ever. It just doesn't work that way.
I think that's such an important point because some of the comments I've heard from other people are because you have a value-driven relationship, so your patients value you time. And so I've heard these things. Well, I know it's my doc, so this is something I know it can wait, so I'll just wait. Or I didn't want to disturb him, so I didn't. And it's not like they're having crushing chest pains and not going to the hospital.
Right.
But it is they know they can access you during regular hours, and then they respect you enough to not do non-urgent things during after hours. And
that's really true. We make it very clear from the beginning. It's like, look, I'm your doctor. You don't have to talk to anybody else. I'm available for you. If you need me, let me know. And these times when I get a call at night, I am so sorry to bother you, Dr. Lehmann. It's like, no, you're not bothering me. Like, you're paying me a monthly fee for me to be here for you. Even people who send like a text or an email, maybe on the weekend, don't read this, Dr. Lehmann. Don't look at it till Monday. So, yeah, patients are great. And I will say, there's a little bit of a fear of, oh my gosh, what if you get somebody who has such severe anxiety, they're just going to monopolize your time. It's like, oh, this is perfect, because I'll give them an appointment every day. And I'll say, look, we're going to do 20-minute appointment every day. And eventually they start saying, can we space the appointments out? And so it's fine with me because I have the time to do it. And it works out great because the patient is being taken seriously. So honestly, I'm trying to think if there's anything bad about doing this.
You have to like being a doctor.
Huh?
You have to like helping people get in and be.
You do have to like helping people. Yeah. It just makes so much difference when you have time and you can set things up to be according to the way that you want. And most docs really want to help people. They really do. And most docs really want to listen. When we all went to medical school, they said whatever, 90% of the diagnosis is history. That's really true. I mean, maybe not 90. But when we were trained, we were really trained to take thorough histories and to really listen and take like a good social history, which is not, do you smoke, do you drink, and are you married? We actually learned about people. And so this to me is actually, it reminds me of medical school. When I go in to see the patient, I have all kinds of time. I just don't have to go present it to somebody when I get out.
Another point here, and I will give Melissa a chance to talk in just a second, but because we're in the middle of COVID craziness, and I just want to return to this because people, well, it sounds kind of scary. I have to go put myself out, and now I'm responsible for myself. But what have you seen, given that with your income and stability with COVID, as compared to what we see now in the traditional medical practices?
0 cancellations. It hasn't. To me, this is like perfect because if I was doing fee-for-service, third party, just the number of visits, even with trying to set up virtual visits, I think most of my colleagues are really hurting because the volume has gone down. My patients know already from experience, they have access to me whenever they need it. They do rely on me for COVID questions. They know that the space is here if they need to come in, but they also respect that it may not be the best to be seen in clinic right now. So I talk to other DPC docs pretty regularly. I don't know anybody who's taking a hit during this. Like they're just sailing along and no stress financially. I mean, short of becoming a different doctor and alienating everybody, once people like enjoy this practice, unless they move, why would they leave? So it has not affected me at all. And I mean, what can I say? I've had 0 stress about what's going on with my business.
That's awesome. I actually makes me think of, so I don't use traditional insurance. I do cost sharing, for my husband and and I personally have a physician, she's now more of a friend, being that, you know, sometimes you have this physician privilege. But I've been paying her for direct care, and it is, for me, even if with me, I am doing part-time anesthesia, that is a fee for service. And I've had a fluctuation in my income, but I refuse to stop paying her, even despite the fact I don't technically have to have it, but I want to support what she's providing and her intentions and the value. And so I just wanted to say thank you for being one of the physicians out there to create the space for so many people to experience it, even though it takes a lot of education on your part to help convince them at times that this is worthwhile. I would love to see this just running rampant, and I know there are people shifting, but for the listeners who are physicians, I think it is a no-brainer when it comes to having a, whether you call it direct primary care or some level of kind of a membership, or, you know.
Or even, I mean, even if you said, I'm just going to charge cash for my services, I mean, whatever it is, just getting back to where there's nobody between you and the patient.
Exactly.
Like, yeah, it's a little frustrating to me because I've done this for 4+ years, and I thought about it for a couple of years. And all of us in DPC, like, say this year it's going to take off, you know, sort of like Apple and iPhones, you know, it took a little while before they really took off. And so we keep waiting for things to take off. But I mean, it is growing. I think so many docs just have their head down, just trying to get through, that they can't look up and see what's out there. Plus, most docs are a little risk averse.
Yes.
You know, they don't like being in a system, but they like knowing they're going to get their paycheck. But I'd love for more docs to know about this. There's certainly opportunities everywhere. And, you know, we shouldn't necessarily say this is all, you know, perfect and fantastic and there's no downsides, because you are taking some risk. You know, you leave the comfort of 2,000 patients in your panel, and you know your schedule is going to be full every day. And so you're taking a chance of, will people believe in me? Will they find the value in this? So, you know, there is a degree of faith that you believe it's going to work to do it. But the more docs you know who've done it, the easier it is to take that leap of faith. And I can tell you the DPC doctor community is probably about 2,000. Most of us stay connected on Facebook. There isn't any of those doctors who wouldn't go the extra mile to help you get other doctors get started. They would say, how can I help? What can I do? What resources do you need? It's like a big club of, we want to make it bigger and bigger.
Yeah, well, I think you open up the bandwidth for that capacity to do that, because you're not inundated with 2,000 plus patients, and it's no longer just survival mode. It's almost like it takes your own personal development to another level and impact people more deeply in the kind of practice that you've created. At least that's how I see it. And I can say, just from making myself go, even though it's not a primary care field, just going part-time or being now on my own and trying to create the experience for patients, that it's so much more fulfilling. And there's a little bit more excitement and joy in doing that. And you want to help other people experience that joy too.
Right.
Yeah.
Yeah. Just the amount of happiness and satisfaction from doing this, you know, I just really go back to, so I was one of these people who loved medical school. Well, the last 2 years, I loved all the clinical stuff. And the thing that every rotation I did, it didn't matter what it was, my number one goal was never lose sight of the fact that the patient is number one, and spend time with them. Like, I don't care how cool the procedures are, whatever else you do, like, it's the person. And this lets you get back to this. Now, if you're not really into this, if you're not into like spending a lot of time with people and getting to know them, well, maybe this isn't for you. But most docs in primary care, I think, really, really like knowing their patients.
Yeah.
And having a relationship that's, you know, sometimes it is a friendship. It's an interesting relationship. It's almost a family kind of relationship sometimes, which I think is great. And that goes back to the small town doc that is part of a community. And this is a community of whatever, I think I have just under 600 patients. And it feels like one big family.
Yeah. Well, do you mind giving a call out to where people can find you in case you're accepting new patients?
Well, I'm not, but I'm the one
Or maybe be on the waiting list.
yeah, the waiting list. I always tell people I don't know when you're going to get off the waiting list because
That's
people just
great
really
for
don't
you.
No, so I'm very interested in being a resource for doctors.
Okay, good.
Because doctors just need to know that there's at least this one thing that might allow them to escape. I would suggest that people go to my website, which is www.vintage.dpc. So it's a vintage practice. Literally, the practice is loaded with old medical equipment and whatnot.
Oh, cool.
So it's vintage, and then DPC is for direct primary care. So vintagedpc.com. And if you're on there, then you can get in touch with me really easily. And I'll take email, phone call, anytime, reasonably. If there are docs who have questions, because we need this to be bigger.
Yeah.
Just pure and simple. We need more docs doing this. Best for patients, best for docs, people being like rejuvenated.
Yeah,
And I don't see a lot of other alternatives.
and I just want to add in there is because I've had some discussions, and I'm a huge primary care fan, and it has always been so disheartening to see primary care doctors go into primary care because they care about medicine. Like they didn't pick the high price specialties. They did it because they loved being doctors. And what I love about direct primary care and these direct care models is it allows, there are very few specialties that can as easily, and I know it's still challenged, there's some aspects to it, but it's not insurmountable anyway. But direct primary care, I mean, for primary care physicians who want to be doctors and want to escape the system and take care of their lives and have, you know, a fulfilling, meaningful practice while making huge impact on patients, it's just this perfect fit. And so thank you so much for coming on, and thank you for being such a resource, because I know you, and I know if someone does reach out to you, you will contact them. And so I'm just waving my little cheerleader things and saying, come out there, you know, do it, because I love primary care folks. I hate seeing how beaten up people feel in these practices. And just to know that there's this option out there. It's so cool. And I always love hearing you talk about your practice, because I'm like, man. So
I love hearing you, Kevin, too. Kevin is the pain resource for me. It's so funny. I mean, we'll end up on DPC, but I don't remember, Kevin, how I even made contact with you. You might have been a CME that I heard way back when.
It was my podcast, my old podcast.
And, it was the old podcast.
And you emailed me. Yeah, it was my old podcast.
But chronic pain, I mean, in primary care, a lot of docs in fee-for-service kind of like dread seeing their chronic pain patients, because takes huge amount of time. And I've learned a ton from you for taking care of these patients, that you just need time. So DPC is great for chronic illnesses because it takes time.
And that made me laugh, because you were talking about, you know, if I had a highly anxious patient, and, you know, my colleagues may worry about that, but all I do is they schedule them on these appointments, daily appointments. And I'm like, that's what I would recommend my colleagues do, is we would have these really complex pain patients, and they're like, oh, pushing them away. I don't want to see them, and try to schedule them out 3 months. I'm like, no, you do the opposite. You schedule them super frequent in your practice, and they will tell you when they don't want to see you anymore. Yeah, and they'll love you for it. And it's like, anyway, so I just love to hear that, because I was like, you guys have the perfect environment to do just fantastic care and take some, you know, again, even really complex patients, and make a huge difference in their lives. So appreciate it.
Some docs think that we cherry pick, like, oh, he went into direct primary care so he could just kick back. Every doc I know loves the most complicated patients because they're real people. I mean, they deserve as much attention as anybody, and that's all they need is time to get to the bottom of things. So We'll take all comers. It's nice to have the healthy ones too, but.
That's awesome.
Well, do you want me to head us out, Kevin?
Yeah, I think we've taken too much of your time. Really appreciate you coming in, but yeah, this has been a
Well,
great episode.
no, this is awesome. In fact, just to recap in general, like, thank you for your infinite curiosity and desire to create immense value for your patients in a very vintage way. I love the idea of this romantic relationship, being a physician, and I think you've recreated that in a way that brings us back in time to what this is all about, and healing and being there with patients and connecting. And I applaud you for all that you've done, and thank you again for coming on the podcast.
Thank you so much. I'm really glad you invited me.
Fantastic. And I am Dr. Katie with the Change Physician Podcast, heading out with Dr. Cuccaro, and we will see you on the next episode.
Stay well, folks.